Good afternoon, ladies and gentlemen. This is Dr. Suthep Udomsawaengsup. First, I would like to thank the organizing committee for giving me an opportunity to share about the bariatric surgery in the Gastro 2023. I would like to thank Professor Valusha as well as Professor Ratagon for the invitation. And also, please have me the apology for not being with you in person in Thailand. I have another commitment abroad. But anyway, welcome to Bangkok, Thailand. Once again, thanks the ASEAN Gastro 2023 collaboration, innovation, as well as transformation. This session will be touching about the how to choose the title weight loss surgery. I'm the director of Jula BMI, the Bariatric and Metabolic Institute. My topic will be touching on who's candidates as well as how to choose, and I'll touch a little bit on the results and trends. So who candidates, you can see that since 1991, studied in NIH, which BMI has you've been well recognized that BMI above 35 plus diseases, or BMI above 40, that's the candidate. Then following that, Asian is coming with the BMI of 32 with diseases, or more than 37. And you can see that globally, there are several regional, national guidelines. This is our guideline Thailand proposed by Thai Society for Metabolic and Bariatric Surgery. So you can see that we use BMI above 32.5 plus comorbidities, or BMI above 37.5 to be a candidate for those who will be beneficial from bariatric surgery. As the NIH since 1991, then 2022 has been an update by SMBS as well as IPSO. So you can see that the indication will be BMI above 30 to be considered for bariatric surgery. And also you can see that Asian population is recognized as the obesity if BMI above 25. So it's been a challenge that what we should explain or should be adjust our indication for the candidate. This all bariatric procedure, you can see that in 1969, it started with open gastric bypasses, followed by VBG, or vertical gastric band gastroplasty, and adjustable gastric banding, which is introduced in 1990. Laparoscopic low and wide gastric bypass has been done in 1994, followed by the mini gastric bypass. You can see there's some different, that the pouch is longer, and they do it as the loop or one anastomosis, or can call single anastomosis gastric bypass. And the most popular now is a sleeve gastrectomy. You can see that started in 2007, but more procedure has been done, and sleeve plus some bypasses has been added. This is a procedure that you may familiarize with in your practice: low and wide gastric bypass, the single anastomosis gastric bypass, sleeve gastrectomy, and sleeve plus some sort of bypasses, which can be several. You can see from these, it could be with duodenal bypass, can be duodenal switch, by partition, SARI, loop, DJB, or proximal jejunal bypass, or the interposition. So it's been under study, especially in Asia, that we're trying to having more data to support the beneficial of these modification. So this is sleeve gastrectomy has been done. You can see that it seemed not to be complicated, and also it very friendly to the patient. This is low and wide gastric bypass. You can see that we make a small pouch of the stomach, and we have a lumen and the BPD limb as the low and wide configuration. So this procedure is very famous, and this is trends. They used to be bypasses, and you can see the sleeve gastrectomy has been the most popular procedure since 2013, and Sleep Plus has been added into the practice. Results. So between sleep and room-wide gastric bypass, in our center, we have done the randomized control trial, and what we have found was that room-wide gastric bypass is significantly effective in terms of weight loss, but there is no different in terms of diabetes control, both in short term and long term. So I think this is the evidence. Also, some evidence from Asia in the meta-analysis, especially for metabolic surgery. You can see that it seemed to be favor on room-wide gastric bypass. This is the comparison, and you can see that it's significantly showing in the first year that it's significantly more effective in room-wide gastric bypass group. But in long term and through the 5 years, you can see that it seems not to be significantly different. But anyway, the study is still going on, and we are waiting for more information. This is from Western, the room-wide, the RCT comparing between sleeve and bypass, or the SM-BOSS study. What I have found in that study that you can see what difference in this true group. It seems room-wide gastric bypass has been showing in terms of weight loss significantly different. And you can see the more standardized of the procedure has been shown on room-wide gastric bypass procedure. Talking about BMI above 50, which more challenging and more complicated cases, we call it super obese patient. So what difference you can see that in the room-wide group had been showing more significant in terms of weight loss and the BMI loss. This is a study from Japan. You can see that with BMI not too heavy, both sleeve and bypass would show not too much different. But in super morbidly obese, you can see that the Sleep Plus, which is sleeve DJB and room-wide gastric bypass, have been showing significantly improved in terms of BMI versus not much. It's been showing, but it's not that effective in terms of sleeve gastrectomy. This is meta-analysis to show, and then you can see that in terms of weight loss has been favor on room-wide gastric bypass, diabetes resolution, and hypertension resolution, especially dyslipidemia resolution has been showing on room-wide gastric bypass. That is one consideration about the effectiveness of the procedure. That's very important to be caught in the how to choose the procedure. Particularly the reflux problem, also one of the concerns. You can see that for obese people, there are several potential causes of the reflux, and been shown evidence that the reflux would be higher in obese group. It could be because of higher hernia, it could be because of pressure and motility and abdominal pressure. There's all the factor to be having more incident of reflux in obese patient. The result of the bariatric procedure, you can see the sleeve gastrectomy. Some study will show the improvement of the symptom of reflux. That might be because of the patient have removed the big amount of acid producing part, but with the increasing of the pressure after having a sleeve gastrectomy done, you can see that more and more information also showing the new onset of reflux, or some would have still having symptom. So this is also very big concern, and that's also very much important to discuss with the patient, especially for those who have reflux symptoms. This is the effects of lumbal gastric bypass. Most of the study would show that the improvement for the reflux problem, some would show the normalized of pH after having the bypass done. So this is also very important in terms of the consideration procedure to the patient. I would be talking a little bit about the single anastomosis gastric bypass or mini gastric bypass. Is a randomized controlled trial, and you can see that it seemed to be not much different between OAGB and the lumbal gastric bypass. And type 2 diabetes, I would say that the OAG might show some more effectiveness in terms of metabolic control. So this is also very important. But what we have seen here is that also, again, the potential complication after OAGB need to be considered. Gastritis, esophagitis, and diarrhea, and some might have to be converted to lumbal gastric bypass. I would say that OAG might be more beneficial in terms of the metabolic control, but the complication need to be also in your consideration. This study also showing that both have been very effective in terms of diabetes control. So then now coming to the strategy to choose the procedure. This is our guideline, our center, or mostly in Thailand, that we use lumbal gastric bypass and sleeve gastrectomy. So we mostly selective the lumbal gastric bypass for those who are super obese, which is BMI above 50. Those who have higher hernia or who have a reflux with significant esophagitis, or significant might be from grade B, that also the big consideration, or they have very severe metabolic disorder. This also we would offer or would discuss with the patient to go with lumbal gastric bypass. But for others, they might doing sleeve gastrectomy with a very good and successful result. Who will be going to do lumbal gastric bypass need to have the very regular follow-up to be preventing the potential of having a metabolic and nutritional deficiency. What I would like to say is that both or all procedure, all bariatric procedure need to be followed up regularly to have the effective of the procedure to be assured, and also to prevent any complication. And sleep plus some bypass procedure need to be in our consideration in the future. And the study has been shown more and more merit as well as potential complication that we need to be considered. Ladies and gentlemen, this is always a study that we've been doing. We also running a sleep plus procedure to compare with lumbal gastric bypass for supermorbidly obese, and also we have some study on liver pathology and other GI diseases. So I welcome all those who are interested in bariatric and the GI diseases to be joining as the multidisciplinary. Once again, what I would like to emphasize for bariatric surgery is that the multidisciplinary approach. So when the patient comes, they should be going to see the obesity activities and group. We have all the specialists to be serving, to be giving the information, and to have the patient to be carrying on all the process of the treatment of bariatric and metabolic surgery. So you can see that we have pre-operative tests, EGD is mandatory, and PS tests been done, and the eradication of H. pylori is also mandatory in our practice. Then we're going to be going to the procedure as concluded before, that BMI above 50 is going to be doing the pre-op weight loss. Now we make it at 1 week acute weight loss, and then we're going to do the procedure, especially lumbal gastric bypass for those BMI below 50, it depending on the patient. But we also advise the patient to be doing the acute weight loss at least 1 week before the procedure. Ladies and gentlemen, once again, thank you very much, and I hope to be working, to be collaborating, and transforming all the knowledge and our practice to be the best care to the patient. Once again, thank you, the Gastro 2023, and please enjoy your stay. Thank you very much.